Assalamu alaikum. I hope so. You are all doing fine. I'm Dr. Muhammad Ali Rabbani, Assistant Professor of Anatomy, and today we are going to discuss how to localize brainstem lesions. This is just a closing talk, nothing new I'm going to discuss right here. We have up till now in the brainstem, I have discussed with you the external anatomy, the cross-sectional anatomy of midbrain pons and medulla oblongata, the lesions of the midbrain pons and medulla oblongata. So I'm just trying to consolidate it, giving it a cap before closing it the brainstem and moving on to the next topics. And if you have not been following us till now, do follow us on our channel and look through the playlist. I have been discussing the neuroanatomy lectures. I've discussed spinal cord in detail and general anatomy of nervous system and the other topics of nervous system. Okay, two things that we are going to focus on. It's which cranial nerves are present at what level and roughly where is each of the tract present. So as far as cranial nerves are concerned, the from above downwards, the first two nerves, olfactory and optic, those are above brainstem. The olfactory is going into the telencephalon part of the forebrain. The optic is from the diencephalon part of the forebrain. Then comes the third and fourth nerve. The third one is coming from oculomotor nerve coming from the anterior aspect of midbrain, and the fourth one, the trochlear nerve, it's coming from posterior aspect of midbrain and then going like this to the front, and that is the after winding around the back surface and the lateral aspect. You are seeing it right here. Then the pons give origin to the four nerves 5, 6, 7, 8. From the anterior surface of pons there is 5 trigeminal. At the pontomedullary junctions from medial to lateral there is 6, there is 7, there is 8. Abducent, facial, vestibulocochlear. So, and the third but not last but not the least is the medulla. It gives rise to the 4 nuclei, 4 cranial nerve number 9, 10, 11 and cranial part of 12. Glossopharyngeal, vagus, accessory, cranial part. And now there is a debate that the cranial part of the accessory nerve, it's not a separate nerve, it is part of the vagus nerve. That's it to what I've written with the reference to the Kaplan's neuroanatomy. By the way, this picture is from Kaplan's neuroanatomy. So that's it. That is how you are going to find which part of the brainstem is involved. The second is major tracts. I will focus on three tracts here: the corticospinal tract, the spinothalamic tract, and dorsal column-medial lemniscus system. The corticospinal tract moves down from the cerebral cortex, corona radiata, antennal capsule, and here it passes through the crus cerebri, base of the pons, pyramids of the medulla oblongata, and then crosses the midline at the junctions of the midbrain. I'm sorry. Then crosses the midline at the junctions of medulla and spinal cord called the pyramidal decussation as it moves down as lateral corticospinal tract. One thing to notice here is this corticospinal tract throughout its pathway remains anteriorly, here in crus, here in base and here in pyramid, and throughout its length it remains near the midline. So medial syndromes will most likely include corticospinal tract. When talking about spinothalamic tract, it already crossed the midline in the spinal cord. It started here, ended in substantia gelatinosa that crossed the midline and came up. And after crossing, it remains almost all the brainstem it remains on the lateral aspect. The spinothalamic tract carrying the fiber from the pain and temperature from the contralateral aspect is usually present on the lateral aspect. So it will be more involved in the lesions that are present laterally. Last but not the least, the dorsal column, the DCML system, carrying the two-point discrimination and special senses, I mean discriminatory senses, and they enter, they move up, and the dorsal column and synapse with the fasciculus gracilis and cuneatus. They synapse with the nucleus gracilis and cuneatus. After that, they cross the midline as internal arcuate, go up as medial lemniscus, and it remains somewhere near the midline. So these are mostly affected near the midline lesions. So when you are given a clinical scenario, or when you are actually looking for a patient and you want to localize what part of the brainstem is involved, then ask yourself these questions. Question 1. At what level the lesion is? Is the lesion at midbrain? Is the lesion at pons? Is the lesion at medulla oblongata? The second question is, at where it is located at that level? Is it located medially? It is located laterally, anteriorly and posteriorly. We will discuss that too. Third, which side it is? Is it the right sided brainstem or left sided brainstem? So these are the questions that you need to ask. How will you answer these questions? To answer these questions, you will go question by question for the first level of the lesion. To check at the level of the lesion, check which cranial nerve is involved. The symptoms that are produced, they are due to the non-functioning of which of the cranial nerves. If it is cranial nerve number 3 and 4, that means the lesion is in midbrain. If it is cranial nerve number 5, 6, 7 and 8, this means the lesion is in pons. If the lesion is in 9, 10, 11, 12, that means the lesion is somewhere in the medulla oblongata. So that's how you figure out at what part of the brainstem the lesion is. Next question is it medial or is it lateral? Out of the three tracks that I highlighted, the corticospinal tract and DCML, it's placed near to the midline, more medially, and spinothalamic tract, it's placed more laterally. So check for the signs and symptoms of those. If there is contralateral spastic paralysis, that means corticospinal tract is there. So it will be in the medial aspect. Spinothalamic will be lateral aspect. Then check for the which side it is. Is it on the right side? Is it on the left side? You can check it by seeing the sides of the nuclei and the tracts. All the three major tracts, I'm sorry, here it is updated. So all the three major tracts, the corticospinal, the DCML, the spinothalamic tracts, they have already crossed the midline in most of them before reaching the brainstem. The spinothalamic tract in the spinal cord, the dorsal column, and the corticospinal tract in the lowest most part of the brainstem. So any lesion of these tracts will lead to contralateral features. So a person comes to you with contralateral spastic paralysis, a person comes to you with the right-sided hemiplegia, then corticospinal tract is affected on the left side. Comes to you with a loss of pain and temperature on the right side, then spinothalamic tract is affected on the left side. Except for trochlear nerve that crosses the midline, all the other nuclei involvement leads to ipsilateral syndrome. If a person comes to you with Bell's palsy or lower motor neuron type facial palsy on the left side, then the left-sided pons will be affected. So that's how you will figure out which part of brainstem is affected. Let's do some practice. I am here using an MCQs from board review series BRS books. I'm not claiming these MCQs as my own, but let us go through that. 10-year-old boy has right arm and leg dystaxia, nystagmus, hoarseness, along with the meiosis and ptosis on the right. Bronchoscopy reveals a paretic vocal cord on the right. The lesion is responsible is most likely the. So first item that I would like you to do is figure out what structures are involved. He has arm and leg dystaxia and nystagmus. So dystaxia, this is something to do with cerebellum. So in the inferior peduncle, cerebellar peduncle is involved here. Nystagmus, that was due to the lesions of the balance nuclei, the vestibular nuclei. So vestibular nucleus is affected. Hoarseness and the vocal cord paralysis. These are explained by the paralysis of nucleus ambiguous. And last but not the least, Meiosis and ptosis both are sympathetic. These are functions that are these are signs that are created due to the loss of sympathetic function. So these are descending sympathetic fibers, descending hypothalamic fibers. So where are these structures present? Vestibular nucleus, nucleus ambiguous, inferior, and these are present at the midbrain level, on the medulla oblongata level. So we have discussed that it is at the medulla. Next, is it medial? Is it lateral? The inferior peduncle is placed laterally. The vestibular nucleus is placed laterally. The descending sympathetic fiber that run with the spinothalamic tract that placed laterally. So all of these point to laterally. So the person is having lesion in dorsolateral medulla oblongata. Moving on, neurological examination reveals spherotosis. Eye looks down and out. Right eye, fixed dilated pupil, right side, spastic hemiparesis, left side, lower facial weakness, left side, where is the lesion? So let us figure out what structures are involved. Ptosis, ptosis, levator pulmonary superior, it's not working. Oculomotor nerve, eye looks down and to the right, oculomotor nerve palsy, fixed dilated pupil, parasympathetic component of oculomotor nerve. So all of these are pointing towards oculomotor nerve paralysis. Spastic hemiparalysis, that is the corticospinal tract involvement. So corticospinal tract involvement, lower facial involvement, weakness, that is the corticobulbar tract. So these are the nuclei that are involved. So where are they present? Oculomotor nerve is cranial nerve number 3. It was present at the midbrain level. So whatever the lesion is, it's somewhere in the midbrain. The midbrain has the cortical spinal tract, midbrain has the corticobulbar tract. Next, what side it is? I told you the lesion is on the same side as the cranial nuclear lesion, nuclear effects. Oculomotor issues are on the right side, the lesion must be on the right side. They are on the contralateral aspect of the three major tracts. The hemiparesis is on the left side, so the lesion must be on the right side. So it is the right-sided right-sided midbrain issue. Now the next question is if it is medial issue or lateral issue. For the medial issue and lateral issue, just ask yourself a question: is it involving corticospinal tract? Involvement of the corticospinal tract almost guarantees that the lesion is near the midline, near the medial aspect. So it is right medial midbrain syndrome. That is the Weber syndrome. So that is the correct answer. Upper midbrain, dorsal midbrain, medial basis of pons, and right side. This is the not pons, peduncles of midbrain. Sorry, upper midbrain, medial basis of crus cerebri, medial basis of midbrain peduncle, and right side. Neurological examination reveals weakness of pterygoid and masseter, left side. Corneal reflex absent, left side. Facial hemiesthesia, left side. What is the lesion? So let's figure out. So weakness of pterygoid and masseter, these are the two muscles of mastication. So it's motor nucleus. Corneal reflex absent, so it can be they have not given the sensory component is missing or motor component is missing. The sensory component is carried by sensory nucleus of trigeminal. Facial hemianesthesia, so this further justifies it our sensory nucleus of trigeminal, and all of these features are through the cranial nerve nuclei, and all of these lesions of the lesion of cranial nerve nuclei are present on the left side. So these are left sided trigeminal nerve damage. Where is left-sided trigeminal nerve present? It is present in upper part of mons in the lateral aspect. So that will be the correct answer. Mid-pontine segment, lateral zone, left side. Neurological examination reveals paralysis of upward downward gaze, absence of convergence, absence of pupillary reactions the lesion is in. These reactions are carried through superior colliculus, and pupillary reaction is through pretectal nucleus, and all of these are present in upper midbrain, rostral midbrain near the back in the tectum. So there is rostral midbrain tectum. So these are the few questions. They are not meant to cover your syllabus or something like that, but I want you to develop the thinking process, develop the way of approaching a problem that you are facing in a clinical scenario and in exams. Thank you so much for listening. That concludes our lectures on the brainstem, and we will inshallah very soon come with the next lectures, other topics of neuroanatomy. And if you have suggestions, questions and feedback regarding this session, please let us know down in the comments. Do contact us. Do find our content on our website, on our Facebook page, on our YouTube channel. You can contact us through all of the social media handles or through the emails and phone numbers that are given here. Thank you so much again. Until next time, goodbye.